This is an educational video from the NYU Langone Orthopedic Surgery Division of Trauma regarding functional bracing, using specific case examples to review indications, techniques, and a brief review of the outcomes literature. Though functional bracing has become a well-known practice over the last several decades, it was initially described several hundred years ago. In 1767, Benjamin Gooch first described functional bracing for tibia and femur fractures. His initial designs are in the top right corner of the slide. Much later in the 1970s, Augusto Sarmiento solidified the technique and concept of early motion facilitating bone healing via functional bracing for lower extremity injuries and then extrapolated it to upper extremity injuries. Today, as thermoplastic orthoses and a new generation of casting materials continue to advance, so does the application of functional bracing. There are several central principles essential to understand and abide by for successful functional bracing. First, it allows early weight-bearing and functional controlled range of motion of the extremity. It requires an intact soft tissue and muscle envelope for maintaining reduction as it encircles and compresses the long bone fracture. The cylindrical shape of the brace provides stabilizing forces internally during muscle contraction. Additionally, it requires a compliant patient who will maintain constant motion to generate hydrostatic forces and controlled micromotion at the fracture necessary for healing. It is important to understand that this technique is best for fractures in which the initial shortening is within acceptable limits. This practice applies the concept of relative stability via secondary healing and subsequent periosteal callus formation. As the fracture edges move against each other, a vascular reaction is generated promoting capillary invasion from the soft tissue to the fracture site, perfusing osteogenesis and promoting union. In the following slides are general contraindications of functional bracing, followed by specific indications for each of the applicable fracture types, along with specific cases demonstrating proper application and use for fracture healing. There are several general contraindications applicable to any fracture type. These include vascular injuries requiring repair, open fractures, fractures associated with significant soft tissue injuries or bone loss, and significant shortening, rotation, or displacement greater than that bone's respective cutoff for operative fixation. Furthermore, fractures in the acute injury period may not be amenable to functional bracing due to the significant soft tissue swelling that inhibits the necessary compression for immobilization and healing. Finally, you must take into consideration the reliability and compliance of the patient. They have to be able to adjust and manage the brace and ensure that there is no skin breakdown at brace edges, or not only will the fracture not heal, but also their skin and soft tissue will be at risk for potentially permanent damage. The criteria for non-operative management of humeral shaft fractures are less than 20 degrees of anterior-posterior angulation, less than 30 degrees of varus valgus angulation, and less than 3 centimeters of shortening. There are both relative and strict contraindications for functional bracing of humeral shaft fractures. The strict contraindication is a brachial plexus injury. The relative contraindications are bilateral humerus fractures, polytrauma or associated lower extremity fractures, as definitive fixation allows early weight bearing through the humerus, pathologic fractures, burns or soft tissue injuries that preclude bracing, and the following fracture characteristics: distraction at fracture site, short oblique or transverse fracture patterns, and intra-articular extension. The first case is a 22-year-old right-hand dominant male who presented to the office 1 week after a water tubing incident during which he fell onto the right arm. He was initially seen at an outside hospital, diagnosed with a humeral shaft fracture and placed in a long arm splint. Injury films demonstrate a distal third spiral fracture of the humerus without intra-articular extension. On his exam 1 week after the injury, he was still tender over the fracture site. His range of motion of his elbow was limited, and there was gross motion at the fracture site. He was neurovascularly intact. At this time, a prefabricated thermoplastic humeral functional brace was applied. It is the senior author's opinion that at the time of injury, the ideal immobilization is a coaptation splint. Then, 7 to 10 days after initial injury, once swelling has decreased and pain is better controlled, you can transition the patient into the functional brace. The first step is to place the stockinette sleeve over the humerus. It should cover both ends of the brace so that it does not dig into the skin. The patient can use their contralateral hand to stabilize the injured side during placement. You then open the brace and encircle the humerus, ideally keeping the fracture in the center of the brace. Make sure it is above the elbow so the elbow and shoulder are free to move. If it is a more proximal fracture, you can use the brace with a proximal lateral extension over the deltoid. This will further control motion and prevent migration at the fracture site. This is helpful but not as critical as a compressive force itself over the fracture site. Then, use the straps to tighten both sides of the brace. The medial aspect of the brace should be up in the axilla and must be well padded. You can use an ABD pad to avoid skin breakdown. The brace is made so that the patient can effectively tighten the straps with only one arm. Once the brace is applied, recheck the edges to make sure it is not digging into the skin. You can always cut the edges and cover with moleskin to adjust to the patient's arm. Initially, fit the brace with the arm relaxed with gravity acting on it so the brace can align the fracture and the arm can accurately be sized for the brace. After the brace is successfully applied, instruct the patient on the use of a cuff and collar, not a sling. The elbow needs to be unsupported to permit gravity traction. As the patient ranges their shoulder and elbow, the activation of the biceps, triceps, and brachialis allow the brace to compress the fracture and encourage healing. This patient returned at 2 weeks, 6 weeks, 3 months, and his final visit was at 4.5 months. The average length of brace use is 8 to 14 weeks, and it should be used until there is both radiographic and clinical evidence of union. Next, we discuss stable ulnar shaft fractures. The criteria for non-operative management of ulnar shaft fractures are isolated ulna mid-shaft to distal third fractures, often known as nightstick fractures, and stable fractures with less than 50% displacement. The contraindications to non-operative treatment include both bone fractures, significant bone loss or soft tissue injury, dislocation of the radial head, proximal ulna shaft fractures, and Montesia fractures. For this, we have a 61-year-old male who presented 1 week after twisting his arm while using a high-powered drill at home. He initially presented to an urgent care clinic where he was diagnosed with a right ulnar shaft fracture and his arm was placed in a splint. Injury films demonstrate a right non-displaced oblique extra-articular fracture of the distal third ulnar shaft. On initial exam 1 week after injury, the skin was intact, there was mild swelling, ecchymosis, and tenderness to palpation over the right forearm. Range of motion of the right elbow and right wrist was normal, and both joints were stable. He was neurovascularly intact. Again, per the senior author's opinion, ideal immobilization at time of injury is an above elbow plaster splint. Then, 7 to 10 days after initial injury, you can transition the patient into the functional brace. Similar to the previous brace, you first place the stockinette over the affected extremity, and it should span from below the elbow to above the wrist. Then, open and apply the brace with the arm relaxed in supination in order to separate the radius and the ulna as much as possible. The tightness of the brace should limit pronation and supination to approximately 50% of normal range. Apply the same techniques from the previous case and video for protecting the skin. As the swelling goes down, the patient should understand how to sequentially tighten the brace with a contralateral arm. The brace should only be removed for showering and cleaning. Finally, the patient should be educated on moving the elbow and wrist as much as possible with no heavy lifting. A sling can initially be given for comfort, but should be used minimally to promote motion. The average length of brace use is 6 to 9 weeks, and it again should be used until there is both radiographic and clinical evidence of union. Lastly, the criteria for non-operative management of tibial shaft fractures are axially stable fractures, reduced transverse patterns, or fractures with less than 10 millimeters of initial shortening. In addition, they must have less than 5 degrees of varus valgus angulation, less than 10 degrees of anterior-posterior angulation, greater than 50% cortical apposition, and less than 10 degrees of rotational malalignment. The relative contraindication is an intact fibula, as a varus deformity is more likely to develop. The third case is a 68-year-old male with medical history significant for coronary artery disease, hypertension, hyperlipidemia, status post-kidney transplant, left hip short cephalomedullary nail in 2019, and left total knee replacement in 2019, who presented to the office 8 days after a mechanical fall while carrying groceries, sustaining a left tibia fracture. He was initially seen at an outside hospital and his leg was casted. Injury films demonstrate a left distal third comminuted extra-articular distal tibia fracture with a concomitant fibula fracture. On the exam, his leg was in a long leg cast and the skin was intact at the edges. The long leg cast was in good position in midflexion. He was neurovascularly intact throughout the lower extremity. Due to the patient's significant medical conditions and comorbidities, the decision was made with the physician and patient to proceed with non-operative treatment and use a functional brace. The long leg cast was removed at 2 weeks and the functional brace was applied. At this time, both the neurovascular exam and thorough skin check were repeated and no new concerns were found. The stockingette was placed to span the leg from the ankle to the knee. With time, patients may prefer to use long socks, which is fine as long as they protect their skin. The brace parts are applied around the tibial shaft with straps velcroed circumferentially at multiple levels. Once the brace is secure and the skin at the edges are checked, you can instruct them how to reapply and tighten the brace. Patients can bear weight with the brace and are instructed to use pain to determine their weight-bearing progression. They should also be instructed to elevate the leg when not in use. In the early time interval, they should avoid long periods of standing as to avoid extra swelling of the foot and ankle. As you can see, this patient actually cut off the bottom aspect of the brace to make it more comfortable for himself. We do not recommend this as this places them at risk for more deformity if the fracture is not completely protected by the brace. This patient returned at 2 weeks, 6 weeks, 10 weeks, 3 months, and at 4.5 months. Although he cut the brace and developed the subsequent deformity, he was walking well and without pain. The average length of brace use is 18 weeks, and it should be used until there is both radiographic and clinical evidence of union. We selected several articles regarding each specific injury to further explore indications and outcomes. The greatest amount of literature available on functional bracing focuses on its efficacy for humeral shaft fractures. The majority of the literature, as seen by 3 of the selected articles below, demonstrates very high healing rates. The risks of functional bracing include skin breakdown, residual deformity, and non-union. The union rates range from 85 to 95% for non-operative treatment. Papastoulis published that proximal fractures, OTA type A fractures, and those with a spiral pattern are at greater risk for non-union. Regarding outcomes, Van de Waal found no difference in permanent radial nerve palsy, in DASH score regarding functional outcomes, or in mean time to union. These are all important points to address with your patient when selecting this treatment option so they may set appropriate expectations. In our literature review of ulnar shaft fractures with functional bracing, there is significant success regarding union rate, decreasing financial burden on the patient, and facilitating ambulation for polytrauma patients with concomitant lower extremity injuries. The residual angular deformity was found not only to be marginal, but to also have a minimal effect on the pronation. This is important when selecting this treatment to ensure maximum post-treatment return to function. For the indicated stable, isolated mid-shaft ulnar fracture, there is no clear advantage seen with operative fixation. Lastly, we review the available literature on functional bracing of tibial shaft fractures. Again, there are high rates of union, all articles citing at least 90% union rates. Here, the most common residual deformities are varus and genu recurvatum, so close follow-up and sequential radiographs should be performed to catch this early and adjust the brace or treatment as needed. When comparing intramedullary nailing and bracing for high-energy tibial shaft fractures, the Bada article found significant differences between the two groups for more time off from work, more outpatient visits, and greater leg length discrepancy. There was no difference regarding patient-reported outcomes on quality of life or function. Sarmiento noted several factors affecting speed of union, including the degree of soft tissue injury, fracture comminution, initial displacement, condition of the fibula, and the time from injury to bracing. Patient selection is critical for successful bracing, as certain patients, like the one introduced earlier in the video, may have significant comorbidities, therefore making it safer to avoid surgery. On the other hand, certain patient or fracture characteristics may make the injury more amenable to definitive fixation. All of these factors should be brought up during the shared decision-making aspect of the care and follow-up for these injuries. Functional bracing continues to provide safe, alternative options for fracture management. When compared to definitive operative fixation, in certain cases, the reported success rates and outcomes are not only equal, but may be superior, particularly for certain fracture patterns or patient demographics. Understanding the indications, bracing techniques, and follow-up is critical to the success of functional bracing. We hope this video has better equipped you to incorporate this treatment option into your practice when the right injury and patient presents.